miles on the clear blue skies. We drive straight as a narrow flies. Nowhere to be, no dreams to chase tonight. We've got time to waste, let's waste it right. You and I, our heads up in the clouds. We're caught up with the birds flying south. Nothing to see as the day turns into night. We got time to waste, let's waste it right. We got time to waste, let's waste it right.
I'm Adrienne Cullen. I'm originally from Ireland. I was treated at the University Medical Centre in Utrecht in 2010-2011. I went to the hospital for treatment. A sample of tissue was taken and sent to the laboratory, but the results didn't come back to my doctor, and he didn't see them for 2 years. And in all that time, the cancer was growing inside me. The response of the hospital was atrocious. We wanted an explanation of what had gone wrong and an apology, an acknowledgement that something had happened at their hospital, and we didn't get that. Well, unfortunately, we were driven to taking legal action. It took from 2013 to the end of 2015, so about 2.5 years, to finally get a settlement agreement with the hospital. We were also told that there would be a gagging clause in our settlement agreement with the hospital, and that really tore us asunder. But we also could not bring ourselves to sign a clause that says that we had no right to speak about what had happened to me in a hospital. And we couldn't do it. And that was one of the most stressful episodes that I have ever experienced in my life. It was very important in our case to go public with what had happened, because the only thing that hospital leaderships seem to respond to is being shamed in public. Hospitals are organizations and they're institutions, and they are deeply hierarchical. And the people at the top live and operate as though they are in a corporate world. They don't have the humility that the medical profession should be defined by. And I think that that change has to happen from the bottom up, because the change is not going to happen from the top down, because the top has been too comfortable where they are. It's all too easy for the patient to be the small person still, and nobody is fighting on our side. When hospitals fail, patients are damaged once. If it isn't handled properly for them, they're damaged twice.
So very stirring and courageous testimony of an awful story. Quite hard to watch, but maybe a testimony that, for that reason, at least for me, makes an appeal to you, urges you to do better. Welcome to everyone to this 6th Adrienne Cullen lecture. We are grateful to Adrienne Cullen that even after her death, she continues to encourage us and to inspire us to keep on learning as hospitals from things that go wrong in order to ensure that similar mistakes are not made again. Also by being open about these mistakes towards family, friends, in that way preventing additional suffering being heaped upon them. So we're showing this report with the permission of Mr. Klasky, the husband of Adrienne Cullen, so that we as hospitals continue to learn from things that go wrong and by openness prevent a repetition of mistakes.
A very special and warm welcome to you, Mr. Klasky, and by extension a warm welcome to Adrienne's family and friends and guests joining us from Ireland today. In het bijzonder de ambassadeur
and especially the ambassador of Ireland. And I'm sure it'll be quite difficult and emotional for you to watch this video. And of course, I want to welcome everyone who's logged on online for this webinar and who is watching today with this 6th Adrienne Cullen lecture on open disclosure after serious harm. And the subject for this year of this Cullen lecture is smooth switching, how to prevent loose ends when transferring patients in the care network. And I want to add to that the term loose ends in no way refers to what happened to Adrienne Cullen or refers to any of the themes of previous lectures. Nor are we trying to say anything here about what might be very painful consequences for patients of what healthcare workers sometimes call loose ends. And before we actually get started, just a few practical announcements. You can follow the webinar in English. There is a separate live stream for that. With simultaneous translation, you can find the link to this stream on the website, but you can also see it on your screen right now. You are probably following this webinar at work or at home or maybe on the road, and we would love to hear your questions and remarks here in the studio. You can do that in two ways. You can send us a message via WhatsApp, and you can see the phone number here on screen, 0683132760, or you can send us an email, and you would do that to webinar@umcutrecht.nl. I'm sure you're seeing all this information on the screen as well. So the lecture, both in English and in Dutch, can be watched at a later date as well. The Dutch lecture, if you're watching that now, is also being subtitled. That is happening live, so it might not be perfect. And then I think it's probably time to introduce myself. I'm Astrid Janssens, Professor of Patient and Public Participation, and recently I talked to Margriet Snijder, the chair of the executive board of the UMC Utrecht, and I asked her about the importance of this Cullen lecture. And let's watch this brief clip.
Goedemiddag. Het is vandaag alweer de 6e keer dat we de Adrienne Cullen lecture houden. Het is een lezing waarbij we jaarlijks stilstaan bij het belang van leren uit fouten en hoe we zorgen dat patiënten zich gehoord en ondersteund voelen wanneer dit gebeurt. Vanuit jouw bestuursfunctie, hoe kijk je terug op die 6 jaar?
Ja, met eigenlijk heel veel trots, maar ook met deemoed. Want de afgelopen 10 jaar hebben wij steeds meer geleerd hoe belangrijk het is niet alleen om te leren van fouten voor zorgprofessionals, maar juist ook om te leren van patiënten hoe we in verhouding tot hen daarmee om moeten gaan. En Adrienne Cullen is ons daarin voorgegaan. En zij was zeer vasthoudend en deed ons dus steeds meer beseffen dat dat echt heel veel beter kon. En dat we niet alleen de fouten gemaakt hadden, maar ook fouten hadden gemaakt in de wijze waarop we met haar en haar naasten als patiënt omgingen. Wat we eigenlijk met elkaar gedaan hebben is veel meer openheid betracht richting onze patiënten. Het bespreken van calamiteitenrapporten, het grotere besprekingen in huis met zowel patiënten en naasten, de professionals, maar ook huisartsen van buiten. Om met elkaar te bekijken wat ging hier fout. De jaarlijkse Cullen-lezing, waar af en toe ook een patiënt in kwam met dienstbehandelaren. Hoe hadden we dit beter kunnen doen? En doordat je eigenlijk die kwetsbaarheid en die openheid daarmee normaliseert, denken mensen, ja, dit moeten we gewoon zo bespreken. En we hebben ook nog een ander iets gedaan, eigenlijk al in het begin, is dat we patiënten hebben ondersteund, patient support. Dat we echt daar veel aandacht aan besteden. Dus niet alleen medisch-technisch, maar juist ook wat betekent dat als je het slachtoffer bent van een medische fout. Maar ook de professionals. Professionals doen het niet met opzet of heel bewust. Dus zijn eigenlijk een slachtoffer van hun eigen medisch handelen en kunnen daar jarenlang heel veel last van hebben. En daarvoor hebben we peer support, collega's getraind die ook de professionals opvangen voor henzelf, maar ook hoe om te gaan met de patiënt. Dat ze zich daarin gesteund weten. Het is wel heel mooi in het kader van het Integraal Zorgakkoord. Hebben wij hier natuurlijk in de regio met elkaar afspraken gemaakt. En daar hebben wij de afspraken gemaakt met gemeentes, het publieke en het sociale domein, maar ook iedereen die waar dan ook in de zorg werkt. Dat het heel belangrijk is om te kijken naar zelfredzaamheid. Wat kunnen burgers zelf doen? Wat kunnen ze naar gemeenschapskracht? Vervolgens hebben we met elkaar gezegd, ja, hoe kunnen we zorg voorkomen? Dat gaat over preventie, over levensstijl, om te kijken hoe werkt dat. Dan vervolgens, als zorg dan nodig is, dan gaan we mensen ondersteunen waar het kan. En dat zijn inderdaad grote netwerken, waarbij dat niet allemaal altijd in het ziekenhuis is of in de zorg. Hè. En natuurlijk passende zorg. Op het moment dat je daadwerkelijk naar een ziekenhuis moet, wat is dan passende zorg en hoe definiëren we dat? En mijn grootste zorg daar is, hoe zorgen we dat de overdracht, de regie, de inzichtelijkheid met toestemming van de patiënt of de burger in die data er is, zodat we weten wie er verantwoordelijk is. Ik denk dat daar ook een hele grote verantwoordelijkheid voor de patiënt, de burger zelf ligt. Maar hoe borgen we die en hoe zorgen we dat diegene dat ook kan nemen? En hoe zorgen we dat als dat niet kan, dat we kunnen inspringen, zodat iemand niet tussen wal en schip valt. Dus dat is best spannend.
Ja, absoluut. Ja, dankjewel.
Welcome back. Margriet there mentioned a number of elements that I want to discuss later with the panel as well. So learning from things, also maybe some patient responsibility, and I'd love to get some response to that here in the studio too. And we hope we can offer you a valuable program over the course of this hour. And again, you can participate in this session by sending an email or sending a WhatsApp if you have questions. All right, so let's get started. I am here with Doreen Zwart. Welcome, Doreen. You're a professor of family medicine and you're also a practicing family physician. And today you'll be talking about smooth switching, how to avoid loose ends when transferring patients in the care network. And in order to safeguard continuity of care in the chain, transfer of handoff of patients from one care professional to another is very important. So I'm very curious what you're going to tell us about that and what we can learn from that. So your lecture is entitled From a Weak Link to Smooth Switching. And again, you can participate, you can send in your questions, but now I will give the floor to Doreen. Yes, thank you, Astrid, for this introduction. Thank you. It's a true honor for me that I get to contribute to the Adrienne Cullen lecture with a story about a weak link that I'd like to change to smooth switching. It's about good transfers or handoffs in the care network. And just to start with that subtitle, a handoff or transfer in the care network, people, when they fall ill, can make very long journeys throughout the healthcare system. So they go from various cabinets to ambulances to hospitals. They sometimes end up in a care home, and then they'll be sitting with care professionals, being in bed while there's care professionals. And all those care professionals are working hard to help the patient as best they can, and then to transfer them to the next care professional, or maybe to send them home. And the patient is kind of a guest with that care professional, with the healthcare worker. But really, in reality, it might be a bit different, because those journeys, the whole patient journey through the healthcare system, it always starts at home. And it almost always ends at home as well. At home, in the patient's environment, and that journey is part of the life of the patient. So you can say, I mean, really, you can change that idea around. The patient isn't a guest with in the health system, but we are guests in the life of the patient. And as long as we keep that in mind, I think that can help us to work towards that smooth switching when it comes to the handoff. So first, the transfer. What is the importance of that? Well, that is the link in the continuity of care. And we know that the better the continuity, the better the patient experience, and also the better the patient outcome. And why is transfer or handoff such an important subject? Well, it's becoming ever more important because more and more we're dealing with transfers, and that's to do with the fact that people are becoming older, fall ill more often, also have more serious illnesses, so they get referred from the family doctor to the hospital more often. Often there's also various healthcare professionals involved, various clinicians, and they'll have to do a handoff towards each other. There's more technological possibilities, meaning you can also provide remote care at a distance. A handoff is important there as well. And there's more and more specialization among healthcare workers. So specialists know about smaller and smaller bits of the patient. So you need more and more people, and they need to do transfers as well. And then often they also work part-time. So there's always more people involved to cover the whole week. So the number of transfers or handoffs in healthcare is increasing. And in the healthcare network, it'll become more and more important. So what is a good handoff? It is timely, it is correct, it is complete, and also compact. So it needs to be quite a handy package for the next clinician that ensures continuity of care. And continuity of care really has three aspects. It's about continuity of information. So are all the bits of important information available at the next station? There needs to be continuity of policy and treatment. So over the course of the journey the patient undergoes, is the treatment consistent? Is there a logical order to it? And then there's also a continuity of relationship. Does the patient feel seen and heard? Do they get the impression that the next clinician also knows all the important things about them? And also you prefer for there to be familiar faces involved. And those three aspects of continuity of care are related as well. So when you ask healthcare professionals about this, everybody thinks this is very important. They know it has to be done. There's guidelines for this, like the HASP guideline, the guideline on information exchange between family doctor and specialists. So there's this guideline drawn up by all the various organizations about how a transfer should be done. So we have this great guideline, but then still there's a weak link, the transfer. And why is that? Because it turns out it is difficult. And maybe just first, is it a weak link? Yes, it is. We know because international studies show that incidents, so things that go wrong, often occur at the transfer moment. Most recent literature still says it's 1 in 5 transfers, so that's 20% of handoffs where things go wrong. So what goes wrong then? Well, often it's about communication and information, and because of that, the other aspects of continuity become less good as well. Communication is often late or it's completely missing. There's lots of inaccuracies contained in it. That's mostly to do with the communication. Also, people use a lot of abbreviations, which are very clear to the person sending the information, but then the next care worker might not understand them at all or might give them a different meaning. And what you often also see is that the questioning is not focused enough when there is referral or discharge, another important transfer. There's just not enough of a conclusion, not enough of a what-if scenario. What should happen if the patient experiences this or this, then who has to take action? And that's very important information for continuity of care. And yes, unfortunately, those incidents at handoffs also impact the patients. And in at least half of cases, it actually reaches the patient. They feel there's something wrong. Sometimes it's just discomfort or, a feeling of not being seen or more delays in care, but in 3% of cases, we know it can lead to permanent and serious harm for the patient. And sometimes it might even lead to death. So it really is important that we get this right. And does this happen at UMC Utrecht as well? Yes, we know this. There's always examples, but also in 2016, we did a study here in the region where UMC Utrecht was involved and some other regional hospitals as well, and a lot of GP practices. And we looked at all the various incidents in transfers and handoffs, and indeed the transfer from one healthcare professional to another. We were able to find 548 of such incidents back then. And if you look at them, you see that the first 3 items that occurred the most, so 25% of the 548 incidents, was about handoff information. About 15% was about referrals, and about 13% was about communication and collaboration. So if you add that all up, over half of the 548 incidents was directly to do with handoff. And so why is that? Well, healthcare professionals do recognize the importance of it, but they sometimes get lost in actually doing it. We all have a protocol, so everybody has that lovely guideline that they have for their own organization. So on paper, everything's perfect, but in practice, things often go differently. So then you see that, for example, certain information is not yet available when a patient is discharged. So then you want really to have all the information ready for the next clinician, but then it's not yet there. Technical systems often don't offer sufficient support. And also still, it doesn't actually get a lot of priority in the day-to-day running of things. And why is that? Because we all think it is important. Well, that is because within our own organization, you know, in my GP practice, but this is also true for hospitals and care homes, you're mostly focusing on the things that you're responsible for. So organizations and cultures are directed inward. They're not so much focused on the perspective of the next clinician, and the here and now often takes precedence, especially in a hospital. If a patient is being discharged, so they're sent home or they're sent to a rehabilitation center, then often they've recovered, they're often doing quite well, and there's always a patient that's more ill that requires your attention, and they take up your time, and then really a good handoff gets lost among all that. And then you can say that really there's no awareness of team outside of the organization, even though we're all responsible for the chain. So this picture, please don't try and read it, but it's just about representing what happens. So what I was just saying is something we've seen in studies. This was a study we did in a larger European context, and we looked at a number of cases, a number of handoff cases, and we did an in-depth study. We looked at all the information to do with that case. So we talked to the patient, the GP, the nursing practitioners involved, the hospital doctors. We've interviewed all of them to ask them about their experience with that particular case. We looked at all the documents, and here you see the little figureheads, and there you see the general practitioner, the patient, and the hospital doctor and the nurse, and they all have their back turned to each other, really. And really, the picture being painted by the studies that everybody's trying really hard, but they're mostly working hard in their own world, in their own silo, and they don't really know and don't really check whether everything ends up with the next link in the chain as well. This is a study from 2012. I checked the more recent literature as well, and that's not really changed, it turns out, but we are working on it. So they are different worlds. Everybody has their own little world. And that's not strange, because, of course, they are different worlds. And as an example, I will use a medical specialist in hospital and a GP. They are different worlds. A medical specialist in their hospital will see a selected patient population. They will mostly see patients where it's already kind of clear that they have a problem in a certain area. It's, organ focused. Cardiologist sees people who have heart issues. A kidney doctor, you know how that works. So it's a selected patient population. And the question that is being asked of them is, please show whether there is a disease. Look into this, get to the bottom of this. That's why they work in a hospital. They have lots of technology there to help them. And a hospital is a big business, which is very efficient, has been signed up in an efficient way with all kinds of healthcare paths. So it's very organized. But GPs, on the contrary, sees patients aged 0 to 100. So it's a very varied population who have a multitude of complaints. It can be anything that they present with. And because there's such a great variety, GPs are mostly looking to exclude diseases. So with this kind of issue, is there a disease that requires medical intervention? So it's almost the opposite question. And GPs are focused on the individual, taking into account their environment and the life of the patient. So that's what we call integral. And of course, we don't have a lot of technology available. Really just it's the doctor's bag that we already used to have. And because these professionals work in these two different worlds, they have a different assignment because they develop a different language as they go along, and they have different techniques and technology. So they have their own world of thinking, and it's hard to leave that world. So it makes sense that it is complicated. So to summarize all that, so really those studies that we did at the time, in 2016 about this, we saw that there's this kind of no man's land between hospital and general practice. There's no active guidance or control there, but for the patients, that is the reality. They move from one place to the other, and that continuity of information is very important, but is difficult because there are differences in language, in tempo, and in focus. Often availability of data has not been coordinated well. The electronic patient files of general practitioners and hospitals don't communicate, so the exchange of data for various reasons is very complex. And then you have continuity of policy and treatment. I was already trying to tell you that specialists have different means of treatment, different goals than general practitioners. So specialists look more at organs in a more specialized way, and that's what they're meant to do, but the two don't always match. And then there's also a problem with the continuity of relationship that is not just difficult for the patient and the care professionals, but also care professionals amongst themselves. There are various clinicians, various healthcare providers. A hospital has to deal with 100 to 300 GP practices, and a GP in the Utrecht region has 4 hospitals to deal with, and they all work just slightly differently. So the whole concept, our healthcare system is based on, doesn't always support cooperation and, putting yourself in someone else's shoes. So what should be done? Well, I think that we need to actively organize a connection between the different worlds. And you do that at 3 levels. You do that by doing something about the structure, by doing something about the culture, and you also do it by making people who work in the healthcare system, who pass through it, making them aware that it is a difficult subject. With the structure, of course, it's about the methods used and it's about technological developments. When it comes to culture, it's mostly about, can you, on the one hand, work on teamwork? Can you make sure that the transfer, the handoff really is something, for example, between hospital and GP, that the 2 clinicians both feel involved and responsible, so you have a shared goal, a shared language, but at the same time you need to be aware that the language of the GP, the family doctor, is slightly different from the language used by the medical specialist. And then people, we need to organize reciprocity between professionals. And I think we should also involve patients. And to start with that latter subject, involving the patients, how could we do that? Well, I would say to healthcare professionals, invite patients to take charge, in part, with the transfer. So to help with that switch, and of course, as a healthcare professional, you have to look at the patient you're faced with, in depth. Is this patient able to help with that handoff? Are they not too ill to do that? Is it hard or easy for a patient to have that overview? Will the patient be happier having a bit of control of that handoff? Of course, you have to ask yourself those questions and then adapt to the answers. But when you hand off patients, then to discuss the handoff with patients, to tell them what you're handing off and what they can say to the next healthcare professional if things go wrong, that is very important. But in some way, of course, you have to remain easy to reach when some things do go wrong. And I'd like to ask patients to join in. Your help really is very important. I've tried to describe that it's pretty complicated to have a good handoff between different worlds, especially because there's so many facets involved. And it helps if you also pay attention, if you raise the alarm when you think, oh, wasn't something else going to happen? It's not happening. Or if there's something that goes wrong, because you might be right. So do feel free to join in and help us to do what needs to be done without you, of course, becoming responsible for this, because the care professionals will continue to be responsible. So what are we working on in order to move towards that smooth switching? Well, in the healthcare world, it's been an important subject to work on for a while now. At UMC Utrecht, for the past 10 years, we've really been working on this. We're working on better technical support when it comes to information exchange. So the electronic patient file needs to be supported. Zorg domain, the referral application, is being redesigned and improved. Possibility of having doctors in-house communicate better with doctors outside of the hospital via teleconsultations, for example. We also do transmural learning and improvements. So the things that go wrong, we put all those together and we try to analyze them and learn from them. And in the region, we're working hard on regional transmural agreements. So among healthcare providers, you're trying to agree who does what, so that we can work together more smoothly. And of course, the handoff is very important there. And as UMC, as a university medical center, we also have the responsibility of working on innovations, on studies to develop new things to best support patients and clinicians in the handoff. Examples of that are things like the warm handover, or projects where we're trying to develop the same language in the hospital journeys of children, and also we're developing network care interventions, and we're really focusing on the transfer and communication there. And one innovation project that I'd like to just go into here, because you can learn a lot from what goes wrong, but you can also learn from what goes well. And that is a project we've also been working on that we did, is in the project Learning from Successful Discharge, the Lego project in Dutch, that is still ongoing. Milou Steenberg, a nursing practitioner and researcher, is looking on this, and we analyzed departments where we know the transfers are going well, so they're timely, correct, compact and complete. And there we looked at how is it possible that things are going so well there. And here you see a very complicated schedule, it's illegible, don't try. But you see that the reality is a lot less simple than the protocol. There's all kinds of side paths, there's variation, but we see in general is that all those actions taken in those departments to have the handover go smoothly are to do with connecting, anticipating, and simplifying. Connecting and anticipating is about looking ahead, and then simplifying as well. And what we're doing now is we're trying to see whether these verbs, which apparently are necessary for a good handoff, we're trying to see if we can introduce them in departments where things are not going so smoothly. So, ladies and gentlemen, I've tried to tell you about handoffs as a weak link towards smooth switching, and my thesis is that handoff is not a link, it is switching, it's not a thing, it's a verb, is what I'm trying to say. And we all have to work on that. And it's up to healthcare organizations to make sure that the structure and the culture are what they need to be. So the organization needs to invest in those things, but it's still work done by humans. And that is the reason I started with that perspective, that as healthcare professionals, we're guests in the patient's life rather than the other way around. And when you're a guest in someone's life and you discharge the patient from hospital or you refer them somewhere else as a GP, then it might seem as if that patient is leaving, but really you're leaving. You're the healthcare professional and you're leaving. And once you become aware of that, then maybe you'll try a bit harder to leave things in the right shape. So we really have to try hard to, every time we leave the patient's journey, that our replacement can take over. And thank you for your attention. Doreen, thank you very much. It was very interesting. I've taken all kinds of notes and I saw some worrying numbers, but what I heard is that this is something that everyone recognizes. Everybody wants to do better. It's a human system, so things can go wrong. So there's all kinds of things I'd like to go into, but we got a question from the audience that I want to present to you. Just very briefly, also maybe a brief response, but you talk about handoffs between GPs and medical specialists. Is it different when you're working with other healthcare professionals, or when you hand off to neighborhood nursing or physical therapist, or is that different? Now, I use that as an example, but a transfer from a hospital to a nursing home or a care home or back home, and then there's local nurses and the GP, there you get the same things. And there as well, you have to guarantee continuity on those three aspects. So that was just an example. Very good question. All right, thank you. Later, we'll come back to some of the things you said in your lecture, but first, I would like to give the floor to a patient who shares her experience about what it is like to be in this chain of healthcare workers.
I'm Faye Burge. I came to Holland with the military, and now I decided I like Holland, so I stayed. My medical condition is not what you say super. I have a chronic sickte with my nose with polyp for 30 years. I have medicine for diabetes, I have osteoporosis, and I have lung problems. Well, I was getting ready for a party and I fell in my douche, getting dressed. I didn't think any more about it, but a couple weeks later, I began to fall everywhere for no reason. So I went to my doctor to see if there was something wrong with my back. So they made photos, x-rays. So then I went back to the doctor and finally they sent me for an MRE. And the doctor was talking to me and said, there's no easy way to tell you this, but you have a tumor on your spinal cord and it's emergency. We need to operate it as soon as possible. I went to the hospital, to the Deaconess, and I sat for a day. And the next morning, the doctors came to me and said, you need to be transferred to the University Hospital in Utrecht. So the doctor operated and took the tumor away, but they could only take 90% of the tumor away. I was transferred to the Hoofdstad in Utrecht. They expected me to stay there 8 weeks. I woke up one morning and I had a swelling, my little basketball on my left-hand side. And so the doctor sent me to the Deaconess. They have to echo gedaan. They didn't find any fluid. They didn't find any twist in my, say, intestines. and I still don't have a really good answer. So then I went for my 6-week control to Dr. at the university Ziekenhuis. He said, I'm gonna send you for a CT scan. This is where the problem begins. I didn't have a good answer from the CT scan. The doctor didn't send sufficient information to my house doctor. I thought I was going to be called if I would get a letter, or that they would have contacted the doctor with more information. No, nothing happened. I'm still waiting. And waiting. Waiting. Yeah, it just seems like everything is being pushed from another to another to another, and there's miscommunication somewhere that I still have the problem, but they're not researching it any further. The quality of my life is gone backwards, not forwards, with this extra basketball on my side. And now I have trouble eating, I have trouble sleeping, I have stomach problems. It's like, and lung problems now are worse because, and it's like that the system doesn't hear you. People don't understand the problems what you're having. Everybody think, yeah, it's good, live with it, accept it. I said, that's easy for everybody to say. You're not me. And I feel like I just fell through the cracks. And I think all of it came back to my house doctor's lap, which I don't think was fair to her either. I said, I'm doing this if I can help somebody else, that they go through a medical problem or something bizarre in a hospital visit or so, that it's not between our ears. They are legitimate problems, and it's important that people listen.
Right, thank you very much, Miss Veberge, for sharing your story with us. Just in all openness, it's very impressive, so we thank you for that. So now I'm going to discuss this further based on Doreen Zwart's lecture and also based on the case you've just seen, and I'm doing that with Doreen Zwart, Professor of Family Medicine, Robert van den Broek, internist of geriatrics, Romy Vijzelaar, resident hospital medicine, and Richard Bos, a patient, and here is a patient representative. So I'll start with you, Richard. Do you recognize this? How did you feel watching this? Yeah, I recognize all of that. Really, I'm quite surprised that the hospital has everything so well organized, but that for me as a patient, kind of as the last link in the chain, that's what I sometimes feel like, that I don't see that. There's so many tools to communicate well, but the communication is not actually happening. So I'm very surprised, especially after the lecture by Doreen. So there's a lot of goodwill and good intentions on all sides, but still they don't have the time or make the time. So you feel like you're the last link in the chain. So that can't be the idea. Maybe, Doreen, you'd like to respond? Well, especially the time. I mean, you're sometimes told that time is money, but too little time is much more expensive, costs much more money. Yes, I completely agree with you. And this is what it's all about. Priorities. It's about something very important. And then I come back to that whole concept of continuity of care. That is something very important that we need to offer, and listening to you, but also listening to Ms. Burge's story. And really that continuity of relationship, when that breaks, that really gives you a feeling of not being seen, not being important, not mattering, even though, of course, that is the whole idea. So, and it's important to give that priority. But it would also be important because not every patient is able to stand up for themselves. So it'd be good to have like a principal physician, like in the past, like a director, bringing everything together, all the open ends, the loose ends, bringing them all together, and who just checks and makes sure, hey, is everything happening the way we've agreed it would? And that's what I'm missing as well as a patient here in the hospital. I can totally imagine. So in your lecture you said, well, maybe the patients can also have part of that control, or you're inviting them to take more control. How do we see that? Well, I agree with what Richard was just saying. You have to organize that someone is in control. You have to have someone in that position in the healthcare organization. That's something you need to prioritize, that you need to give time to. But the question I'm asking patients is that, you know, when you refer to a new clinician or you move from the hospital to home because you're discharged, or to a care home. So what I'm trying to say is that we have to include patients in the fact that that is a risky moment, and that it helps if they think about this too, and that they shouldn't feel bad about raising the alarm, saying, hey, wasn't I promised something different? That can only help us. Yeah, but then if you have to help thinking about something, then you have to communicate and people have to listen. And if I'm telling you something, but you, as your receiver is not, your antenna is not working well, then you can place all the initiative you like with the patient, but it won't get you to the goal you want to get to. No, but I'm not putting the initiative with the patient. But of course, the transmitter and the receiver have to stay connected. Contact is very important. Well, I think that a care director or a principal physician should be the antenna for all that communication, and they should make sure that everything is running smoothly. And we have so many lovely tools to do that, and we don't use them often enough. Yeah, but maybe I can just add to this. Might that be something we need to learn, taking charge or being a director of that? Romy, you're a young doctor. Is that something that you learned during your training, the transmural part of things, learning handoffs? Or, well, really, in medical training, as I remember it, it doesn't really come up. And that's a shame, because then you get to work and then you really learn it while doing. So is that something you see in practice as a young doctor, or is that a rare thing that happens? No, you definitely see it. And I think, you know, Doreen described this very well in her lecture. At every moment, at every point where a person moves from one clinician to another, and I mostly work with patients that have been hospitalized. So there you have the moment of hospitalization and discharge, but those moments occur day to day, so it's proven very important. But you don't really learn how important it is until you actually start doing the work. At least that was true for me, and I think much more attention should be paid to that beforehand. If I can just add to that, what you're seeing now, and what you'll be seeing over the next few years certainly, is that the patient group will become more diffuse. People won't have just one problem, but several problems. They'll have their main problem and then some secondary problems. So who should they go to? Also, you'll see that the healthcare professional, as Doreen was saying, is becoming a doctor that is more specialized. Very good at problem A, might not know a lot about problems B, C, and D. So how do you deal with those two developments, and how do you make sure you still have a tailor-made approach? Of course, ideally, you want the framework to be right, prerequisites to be right, so that you have, for example, easier communication tools. We're already seeing some progress there, also national legislation about communication, but also in our hospital you can already check the files at different hospitals, so you have more information available. And in addition, you're seeing that in our region we're working on understanding the patient journey better and better, and to make agreements about that as well. Doreen was referring to this as well. So regional transmural agreements. So a person in our region with memory issues, who should the GP refer them to when they can't help themselves? And then we have kind of guideline for these kinds of problems, go to this hospital. For those kinds of problems, go to the other hospital. So that provides much more support. But in spite of all those agreements, I still think the foundation, the basis is, and this is true for every healthcare worker in the Netherlands, is that you've chosen this job to help people. So you have that responsibility. You must feel responsible. And you're working with people. People can have allergies. People have emotions. So it's never done by the book. But you have to be able to deal with that. And by taking that responsibility, you have to take the patient to the person who will take over the problem if you think you cannot help that patient. So that means we have to look in the mirror and ask ourselves, how would you want to be treated if you were in their shoes? And where does your responsibility end? And we do that, for example, on our ward, and you might recognize this, twice a week, all staff, nursing staff, doctors, everyone gets together to discuss the environment of the patient. Who is Miss Pieterse? How does she live? What does she need exactly? And we get the medical expert involved as well. What exactly is she suffering from? And then you get a tailor-made approach, and then you can provide good health care. And that's done elsewhere in the hospital as well. I know the oncology department is doing that as well. They have the GP call in to the oncologist discussion, and the GP can tell them something about the patient. The oncologist can have the expertise, share that with the GP, so you get a tailor-made approach. And that is how we need to continue to find each other. And I think that's in line with the needs you were describing, Richard. Yes, because if you're asked to help think about your whole treatment plan and you might get access to the file, then the file will need to be more understandable for patients. I found information about a consult that was 7 lines with 12 abbreviations, and I had no idea what any of them meant. So that communication would need to be appropriate to the charge you're meant to be taking as a patient. So communication on all fronts, I think, should be taken to a higher level. Yes, if I can just add to that, because you said previously that sometimes, it can be more expensive to take less time, to use less time. And I can remember very well that in my first year, there was a case at one point of a patient who was hospitalized from a nursing home with bladder infection had gone out of hand, and she needed an infusion every day for 2 weeks. And the first time, I was in charge of her. A few months later, she came back, and then a few months later, it was a third time, and only then did I think, hey, can we not change something about this? And long story short, but in the end, what we did is we invested the time to plan a meeting with everyone involved, also people at the nursing home, within the hospital, various specialists in various areas. So we took the time to just sit down together and see how we could break that vicious cycle. And in the end, that helped. So there were fewer hospitalizations, much fewer. So that was really a learning moment for me. And I think, it takes some time. And probably not everyone has that time, but if you take the time, it does bear fruit. Well, I had an experience with a doctor where, 4 times a year we'd go there for a consultation, just rush through that in 10 minutes. It's like a little play you did every time. So I've now reduced that, at my request, to 1 consultation once a year, and then you get 30 minutes. And that's much more helpful to me. Rather than those 4 short 10-minute consultations you rush through. So that's very important to me. It also saves a lot of money. I don't have to travel here anymore. It saves the hospital's costs as well. So you can do even more of a tailor-made approach. So I noticed that that is something that can be done. So you say you prefer once a year and then 30 minutes. What makes the difference there? Well, if I'm here once every 3 months, I don't always have any something to report. So you go to the doctor and then they ask, Richard, how are you doing now? And then I say, well, I'm all right. Well, that's good to hear. Numbers looking good, and I already knew that because that is in my file. And then, we'll see each other again 3 months from now. So then I said, let's not do that anymore. It's better to maybe just be here once a year. And then he said, well, it's not the policy. I said, well, it's my policy. And I said, let's just try it. So I managed to get them to agree. And of course, we also agreed that if anything happens in the interim, if anything crops up, I can just call them. And then, the file leads us to the next appointment. Right, so really you've created a model there that suits you and in your continuity of care. And then the policy is still consistent, the information is then all on the table, not just half of it or a third of it. And then you also have a better relationship, and I think that's very important to be aware of that. That's something we need to work on. That's another example with Miss Birch. Of course, listening to her, apparently she was treated quite well in hospital, but then the unexpected stuff that cropped up, all that kind of thing, they apparently didn't fit in with the rest of the picture, so then they fall by the wayside. They slip through the cracks. And then you don't get the feeling that all of it was good care, so that there was really continuity of care, and we need to focus on that much more. That's how we need to organize. And you do that together with the patient. And I also think the patient portal is a great key to communication. I've had great experiences with that. And also the response is great to it. Often you get a response within a day, and often it can really put your mind at ease. And that is why I was happy to agree to one consultation a year rather than once every 3 months. Because your clinician can be reached via the portal quickly, right? So that is it's a nice tool. Yes, so that's a relationship that is being supported by the system. Very nice. Because the word's not yet been said, but I am kind of hearing this with what Miss Birch is saying, and what you were saying as well. That's trust. I think Miss Birch probably somewhere along the story lost her trust, her faith in the system, and you, Care, might have a bit more faith in the system. So how important is that, and how can we work on that? Yeah, absolutely. I mean, trust is essential. It's the basis for working together. Healthcare is always about the relationship that you have. You have a patient and you have a care professional, and together, and we say you decide together that it's appropriate care, but the condition for that is that there is trust. So the patient should be able to trust that the care professional is communicating in a timely fashion, in a complete fashion, also is honest when they don't know something. And that's a good example. I think she mostly lost faith in the relationship, in the fact that probably it doesn't make a great difference to her that, healthcare professionals are not sure what's wrong with her, but she would have appreciated them saying, well, I don't know what it is, but I propose we do this. Maybe we can refer you to this person, that person. Right, some openness, you mean? Yes, because trust is also being open about where your limits are, what you can do for someone and what you cannot do for someone. And sometimes we find that difficult to be open and clear about that, because then we're afraid that we're, harming or hurting expectations. But my experience so far has been that openness ensures a kind of symbiosis with the patient, because you say very clearly, oh, this I can do, this I cannot do, this is why you should come to me, and for this you should go to someone else. But then, of course, you have to make sure that there is a follow-up to that. Right, because it's not just the trust between the patient and the healthcare professional, but also the trust between the various healthcare professionals in the chain or the network. And when you say, oh, I don't know, but I will transfer you to someone, and I'll ask them whether they know, and it could be being sent back to the GP, so they look at it in a different way, or being sent on to another medical specialist, but at least to put the next healthcare professional in the position of doing being able to do the right thing, also giving them all the information you've had so far, that will help you along. And then it would help if, you know, throughout the chain what you need from others. So you have to regularly look into your colleagues. You know, what can they do? What can they not do? How can I put them in the best position to help the patient further? What information do they need to do that? And then you need to know what language is being spoken in the next link in the chain. I'll come back to you in a minute, but just very briefly, because we have a question as well from the audience. And that trust between the healthcare professionals, I think, is something that has to grow. So then what about young doctors? And again, the question has been asked, you know, education or training, how important is it, and how can we help people through that? Well, training when it comes to transmural care? Well, handoffs, but also maybe just knowledge of the healthcare system, like who are my potential partners. Oh, that's a very good point, because that is also something that I feel did not come up nearly often enough in my medical training. You know, what does the medical system actually look like? How is it set up? Who operates where? And what means or resources do they have? And that is something that you do learn as you go along. But there, you know, you make mistakes and then you recover and you do better. But I think there, having experienced doctors around you is very important. And I've been fortunate enough in my current training to do traineeships both within the hospital and outside of the hospital. And right now I'm outside of the hospital, so I can experience everything from the other side, you know, what it's like. For example, when information is not clear, or how hard it is to get a hold of someone, just to give an example. And I think that would also have a lot of added value if you get to experience both sides. Yeah, the two worlds or multiple worlds. Yeah, there's multiple worlds, and you need to be able to look at things from very different perspectives. Even though you only work as a GP, you have to understand what the others want from you. And the same is true for the hospital. And you have to keep on working on that and update that, because if you're somewhere for 10 years, you forget about the rest. So sometimes you need to just look around and invest in that. Yeah, so now we're seeing a certain development. We're seeing the development of new curriculums for new medical students. And there you see much more attention being paid to the various roles you play as a doctor, but also in the different settings. So that's in hospitals, in nursing homes, in GP practice. So the curriculum of the future will include much more intra and extramural portfolios. So that's a good development. And also curriculums right now are pretty full with information just to become a good doctor, but there's more and more attention being paid for non-medical competences. So now that's still part of a certain kind of the education. But I think also just on the floor, on the work floor, the training team or every professional has to know that they're a role model for the younger people just learning, because you have to set the right example. So show that every day what you stand for. That might stay with people the most, you know, compared to the formal teaching moments. Certainly, yes. And I interrupted you. Did you want to say something else? Yes, just to add to what Doreen was saying, because most people who are referred by a GP, you know, they come to a doctor in a hospital and they expect them to be like a miracle worker. That doctor is omniscient and they will make me better. And then they're being told, oh no, that's not my thing at all, that's not my specialism. And then the patient's world kind of falls apart. They have to go to a different hospital or to a different clinician, and they might not know, because you have to tell them the whole story all over again. So I'd almost say maybe just sit on the patient's chair as well and try to experience what a patient is experiencing when they go to a doctor for the first time in hospital. And that is an important story as well. Definitely. It is a very important point I think you're making. I think also that takes us back to the heart of what we were talking about today, and I fear we now have to wrap up. It was a very interesting panel discussion, but we're already out of time. So I want to thank the people at home or people at work. I want to thank them for logging on to the webinar, but especially my guests here, of course, Doreen Zwart, Robert van den Broek, and Ronnie Vijzelaar, and Richard Bos. And of course, I want to thank the people who made a contribution via video to today's lecture. And if I can just take something away from today for myself and maybe something to share with you as well, it's very important to first of all be aware that there are more worlds, and that you have the assignment that it is your job to sometimes put yourself in those other words, and that is an exercise in humility that perhaps we should perform more often. So I wish all of you a great afternoon, and thank you very much for watching.